Epidemic Advisory Council meeting. I am Deanne Bullock, and Claire Bolts is my co-chair as well. I think everybody knows pretty much who we are, and Morgan as well. So thanks everybody for attending today. We do have a few non-council members joining us today. So if those people just want to go ahead, I guess we can kind of go in a row, Morgan with the non-council members, and just have them do brief introductions.
Sure. Justin, do you want to introduce yourself?
Justin Igatibuke, epidemiologist at the Health Department.
Thanks. Dash. Well, we know Dash, but
hello, everyone.
not everyone.
It's me, Dash, again, North American Regional Director for Fast Track Cities.
Dr. Brown.
Hello. So I am Lauren Brown, and I am the Director of Trauma and HIV Studies in the Center for the Study of Social Determinants of Health at Meharry Medical College. And I'm an assistant professor of psychiatry and behavioral sciences there. And I am working in the Trauma-Informed Care Cultural Humility subcommittee. Thank you for asking me to join.
And Dr. Alexander.
Hi, everybody. This is Leah Alexander. I'm the director of the MPH program at Meharry Medical College. Glad to be here.
Awesome. I feel like are there more people? Esty, I saw an Esty Harris, but okay, looks like they're not there anymore. Okay. So that's everyone, I think, for now.
All right. Did we forget anybody? If anybody got forgotten, please raise your hand and we're happy to let you introduce yourself. And nobody else has joined us as far as quorum, so we will move our minutes to the bottom of the agenda probably right before we disband if we have quorum by then. So I'll now hand it over to our EHE work group co-chairs to go ahead and give their updates. Looks like we're going to start with, is anybody here from U equals U?
I'll just give that update. Oh, Claire, do you want to give the update?
Sure, I can. So the U equals U task force has been really working on recruiting ambassadors to serve as, or to be photographed and share the message of U equals U on their social media accounts. And we had, I believe it was 7 applications when I last checked, and I actually have not checked since the cutoff date, which was the last day of July. So we may have gotten a few more since then, but we were really excited at our last meeting with the applications that we had gotten, and it was really interesting and diverse group of people. So next steps are going to be reaching back out and selecting people to serve as ambassadors and getting photo shoots set up with the photographer that we're working with on that project. And then we'll be sharing the content that is created as far as and wide as we can. So that's about it.
Thank you, Claire. The photo shoots are scheduled for the end of this month, so it's exciting to have made as much progress as we have finally with this project, so really exciting. And the prevention work group, I'll give an update for that as well because Abel isn't here. So the prevention work group met last Wednesday, the week before last, and they hadn't met in a couple of months. And so we talked about progress on the PrEP resource that the work group created in the spring and talked more about a distribution plan for that resource. And right now we're trying to determine the target population for the resource and what form of distribution the resource will take, whether it will be like a flyer or something like that. And we also talked about group engagement and trying to come up with a solution, because we've had a lot of members who have, stopped attending or who aren't really engaged in the work group activity. So we had some conversation around what we can do to change that. And then equity or trauma-informed care work groups, do you all want to share?
Leah, do you want to jump in first and then I can follow? Are you still here? Oh, maybe she dropped off. Do you still see Leah on here? Dr. Alexander? Okay. Well, I can start with the trauma-informed care. I don't think there's a ton to add since our last update, which I think was relatively thorough. Just that we finished collecting one-on-one interview data with folks from 5 different HIV care, the biggest 5 HIV care institutions in Metro Nashville. We haven't engaged prevention yet, but we did one-on-one interviews. We have since analyzed that data, and it's a lot of data. And so we are working now to roll it into something that is digestible for stakeholders. And we're working on a dissemination plan. And we have a retreat scheduled for August 23rd. And I'm not sure how big it's going to be, but we've invited about 5 members from each institution to really help us understand what the findings mean and to really create, we're going to follow the model of community-based participatory research so that we really go into a partnership metro-wide, which is going to be a big undertaking, but we're hopeful. And basically just to come together to what recommendations the group has for how we can move forward with implementing trauma-informed HIV care across Metro Nashville. And I should state it's culturally responsive trauma-informed HIV care, which to me that's kind of redundant, but just saying that because there have been trauma-informed efforts that have not really been culturally responsive. And so yeah, I think that's the biggest update. I'm realizing now that we really didn't think about inviting or including any of the council on that, even though it's very much an EHE project. And so certainly open if anyone here wants to participate in some way. We can talk through what that might look like. And I think that's it. Claire, am I forgetting anything? Do you all have any questions?
Hi guys, it's Brandon here with the mayor's office. Lauren, I have one question for you. I may have missed it if you mentioned it, but who are the 5 institutions?
Yeah, sure. That's a great question. It's Vanderbilt's Comprehensive Care Clinic. It's Nashville Cares, Metro Public Health Department, Streetworks, and Meharry Wellness Center.
Thank you.
Absolutely. And like I said, we haven't engaged with prevention yet, so certainly not intending to leave anyone out. And if there are other institutions who want to participate, we definitely want folks to participate. This was kind of just, a starting point to get things moving. Leah, did you want to jump in and talk about the equity work group?
I can a little bit. I'm a little disconnected from our group because I haven't been participating as much. So I don't know how much I can add, and I was texting to see if Tariq was going to be able to join. But as far as the equity lens that we've been developing, I think we're ready to roll it out. So I don't know, would it need to go to this group first before we distributed it to the other work groups?
That was a key question that we had.
I mean, I think we're at a point where we could share it with this group and then, roll it out for folks to use. That's been my most involvement, I think, with our work group. So some of the other stuff I'd really have to rely on Tariq to provide the update.
Yeah, this is Meredith Brantley.
Hey.
Could you share a little bit more about what you're referencing? Because I'm somewhat new to this group, and I don't know if I'm like kind of in the know on what y'all are working on. I'm curious to hear a little bit more.
Yeah, sure. So it started probably before the pandemic. I think there was a concern about whether or not folks are centering equity in their work. And so we were charged, and I'm not sure by who, but we were charged to work on developing an equity lens that folks could use to assess their projects, assess their organizations, and start conversations around equity. And so we reviewed several different ways to do this, several different models, and developed a tool that we eventually wanted to roll out to some of the CBOs and organizations that are involved in EHE. So it's been a while that we've been working on it, but I think we're ready to at least let this committee take a look at it and chime in on it, and then roll it out to the group.
I'll jump in and say, I think Julie mentioned it in her last meeting with the council back in December, Julie Thacker. And the last thing she said to me about the whole thing was that she thought we would pilot it with the projects that the prevention work group is working on. So I don't know if the council still needs to, I don't know. Do you all remember when Julie shared that at the last meeting she was here for in December?
I don't remember that, but I do recall, so Dr. Alexander, the equity work group was the first recommendation, I believe, that the advisory council made, was that work group be formed to ensure that especially that any work done for EHE was going to be done with an equity lens. So I think it'll be really important to also share that with all of the work groups, and so that they can use it moving forward with any of their projects. But I'd love to hear more about it. I don't know if, Morgan, if we have time today, or if you all are prepared to share any more today, but at some point I think that'd be great.
I'll just jump in and say I would love to share more about it. So maybe at the next meeting we could share it. People could see sort of what we developed, and then we could just make a plan to roll it out. Because I think we could continue to work on it, but that may keep us from moving on it. And I know the concern is getting it disseminated and having people use it. So maybe for the next meeting we could have a little bit of time and we'll share what we developed, and people can chime in and give us advice on the next steps. How does that sound?
That sounds great. And I'll reach out to you separately about this, but and I think we're a little I've been organizing a live event for not just council members, but anybody in Nashville who wants to be involved with EHE. That will be September 30th. And I think that would also be a great place to have more discussion around the equity lens.
Okay. I'll put that date on my calendar.
We do have quorum now if we want to do the approval of the minutes.
Or I can do that. Hold on just a minute. All right, so we have the minutes from our last meeting. Minutes were from June 2nd, and I believe they were sent out on the 30th of July. Does everybody have the opportunity to review them who needs to review them? And if not, we can just take a minute or so and have you review them. For the people that have reviewed them, are there any changes or amendments that need to happen? And if there are no changes or amendments, would someone make a motion for approval, please?
I reviewed them and I move for approval.
Thank you. And a second?
I'll second.
Okay, all in favor? Hands. You can just raise hands, I guess. That would be easier if you're on camera. All right, thank you. All right, we will move on to the new business. Claire, it looks like I'm turning it over to you.
Yes. So next up, we have Dashiell Sears joining us to discuss some next steps for Fast Track Cities Nashville. Dash, I'll let you take it away.
Thank you very much. If it's okay, I'm going to go ahead and share my screen very quickly and just go over a couple things that I think would be excellent for the next steps. Okay. So, as part of the Fast Track Cities grouping, Nashville is looking to develop deeper relationships with other Fast Track cities and also developing what kind of Fast Track city it wants to be and where it wants to go. And I've already heard that you're doing a community event on September 30th, which is excellent because I have some great ideas for what that could look like and possibly include, just as an opportunity to kind of continue that track of including more community is excellent. Well, the first thing that we're looking to do is we'd love to develop a clinician key opinion leader. So someone who is part of the Nashville community who is not necessarily a part of the health department, but is someone who is a clinical care doctor who serves patients with HIV, or someone who's a highly visible and respected HIV researcher. And in doing so, I would send the terms of reference for this person to be the clinician KOL. It's a set of guidelines of what it means to be a clinician KOL, someone who is informed about the HIV care and clinical care in the Nashville region, as well as someone who can speak with authority when it comes to what is going on in the clinical setting for HIV. It's just one stakeholder who is part of the grouping of everyone, but it's someone who can say, I can take this on in addition to the clinical work that I do, which is why it doesn't have to be someone who dedicates all their time to it, but it's someone who's already involved in the planning part. And again, someone who's not necessarily part of the health department, but is someone who is a clinical care provider themselves as well. From there, we are developing Nashville's Fast Track Cities dashboard. You may have seen some emails from me asking about community headshots and messages. We recently, actually this week, had a meeting with the epidemiology department at Metro and are going to have a data exchange for the epidemiology information. We've provided templates for the data that we asked for, and that will be coming to us soon. I did some background research on some HIV service locations that were available and offered in the Metro region. So I provided that back to our partners to be put into the dashboard as well. And before we launch, I always send back the dashboard itself to stakeholders within the city to basically get the all clear that this is what the dashboard looks like, the information is correct as far as the data, and then we do a launch. The launch could be either at an event to make it very public, or it can be, hey, we're launching and we share it on Twitter. But essentially the launch means it's live, it's public, and anybody can then access it. We take off the credentials that kind of block it off. So right now it's kind of present being built, but it's blocked off for right now. From there, we would love to do a convening to basically show the community the dashboard and talk about this as a tool for the community. What else would we want on that dashboard as far as resources, as far as any additional data that you would want tracked, and where could we get that data and what would need to happen for that to work, and why. We want to make sure this dashboard that we develop is the best community tool possible. And if there are already other dashboards and other resources being built, making sure that we connect them together. We want them to agree with each other, and we don't want there to be a disalignment. And it can track anything that you would want, as long as that data is there and the community says we want it to be tracked, then by all means, we can place it on there and find a way to bring a visualization to that data for whichever data that you want tracked. People have done things like for housing affordability, the availability of a test per region, and how quickly you could get one. So there are different ways to look at what could be presented. And we have talked, I've heard about the community meeting on the 30th. So part of what we did not reach during our implementation workshop is completing a strategic objective and action table during the first workshop. We were doing a lot of discussion at first about the alignment, and we had a great conversation. We just kind of ran out of time. But totally fine. I think this would be an excellent opportunity at the community event to bring that up and talk about what are some gaps that are occurring between the involvement of the EHE plan, the development of the EHE plan, and the implementation. What would be needed, especially if it comes from the community of which it's meant to be addressing under the pillars. And from there, what we're identifying is not the biometrics and the biometric gaps when it comes to HIV, but the social determinants of HIV, the political determinants of HIV, how people interact with this plan or interact with the services which this plan is meant to address. From there, you have a strategic objective and an action table that can be included into an implementation plan for EHE, saying this is how we're going to implement EHE, and here are some additional things in order to help make this work the best for the community as possible. And I feel like this community event is basically already, like, that's the point of the community event, to have that inclusion. So you're already there. I didn't really need to, like, we don't need to set it up. You already have that ready. So that's excellent. What I do want to offer, though, is a best practices repository. We have 2 of them right now. They are, I have hyperlinks to them. I can also send these links directly as well. But these best practices are, we utilize a rubric that's graded against the WHO best practices grading rubric for anything that works for HIV, services, harm reduction, PrEP uptake. We have a ton. I can actually just show you what they look like right now. We can. There. So our first best practice repository has an international scope when it comes to programs that are developed by different fast track cities around the world. They feature not only a little bit about like what their primary audience is for, but there's a description, and it goes through how they developed it and how they implemented the best practice. And then what are some lessons learned from that best practice conclusions, as well as supplemental tools and resources, and the contact information for the initial researchers who developed this best practice and implemented this best practice. And that's true for all of these best practices. We also have a second repository that's through the web portal where we're merging them both together. these are other kinds of community-based best practices. And again, you can read more as well. What I would love to see happen is for the strategic objective and actions that could come out from a community discussion that will happen on the 30th to be matched with what's needed and to peruse the best practices that are available to see what's some best practices that could help identify a solution to an identified problem that comes from the community. Say, what's something that could work that fixes this issue or addresses this issue that's been brought up. And then more than happy to connect anybody to those individuals that developed those best practices or implemented them wherever they are in the world. And then finally, I'm going to go back to and then finally, city-to-city meetings. There has been some interest in connecting with other fast-track cities inside of the US to talk about what they have done for their own inner workings when it comes to fast-track cities work, EHE work, how they've worked as a city specifically with developing their own ways of funding their harm reduction or HIV strategies without the state. And I feel these cities, Denver, Austin, Phoenix, and Baton Rouge, they are all capital cities in similar situations when it comes to their political dynamic between their state and they themselves as a municipality, as a city. Some of them are city-county integrated. Some of them are cities that are residing in counties. I think having an eclectic view that kind of covers a lot of them through these cities would be very helpful to answer a lot of questions that are specifically about maybe city administrative work or political dynamics and how they've worked, as well as their interactions with public health administration just in general, and what they've done for HIV. For example, Maricopa County for Phoenix, they identified an issue that came up when they decided to pay for individuals lab tests in order to get PrEP, was as they were paying off these lab tests, they identified that many people were still not able to receive PrEP because they had standing balances against their PCPs, and their PCPs would not give them prescriptions until they paid off their PCP balance. So now they're working on trying to find how can they address that. So they have like worked on several things that they're getting to a level that they're finding out new things. I think it's very interesting, but something they could talk about and how they set up like what they've done. And that's just one example. If that's something that's already been worked on, it's great. But I think it's something like a city could really talk with another city about that I can't really explain directly. It really has to come from them. I am more than happy to start setting up these meetings. I have talked with these individuals from Denver, Austin, Phoenix, and Baton Rouge, and all of them are saying, yeah, we definitely would love to talk with Nashville. What I would love for Nashville to really think of is, what would you want to know? And kind of like a quick print agenda of like, here are things we'd love to ask other cities, and that way I can like forward it to them as we start setting up like a city-to-city meeting. And then my last thing is a pitch for Fast Track Cities 2022. It will be this year, October 11th through 13th in Sevilla, Spain. It is hybrid, both virtual and in person. So we have free registration codes that can be used for up to 5 attendees, good for both in-person and virtual attendees. So if you are looking to join us for Fast Track Cities, either in Sevilla or virtually, you can up to 5 free registrants. All right, so that is it for me. I'm happy to take any questions. If anybody has any concerns, questions, anything I can talk about. My next steps would really be to continue connecting the city to cities. So we have groups that can meet together from the EHE and FTC groupings. And also, I would love additional community messages, headshots, and little brief messages that can be placed on the Fast Track Cities dashboard. So when it launches, there's, the homepage is going to have like a listing of the community members that have quotations about what it means to end HIV now. Wondering if anyone here was either went to Montreal or attended AIDS 2022 virtually. It was very eye-opening that the UN AIDS report came out and said that we were in danger of losing a lot of the gains against HIV globally. And it was a very stark reminder that HIV, unfortunately, has been deprioritized and really gutted because of COVID. And that's a huge issue because it's coupling that with a lot of the movement against HIV ever since really PrEP came out, and really ever since HAART really was enacted, was developed and put out, that it's lost the public eye. And unfortunately, without that public eye on there and without that continued effort, it really continues to change and continues to see huge growth when it comes to new cases, especially amongst the young people, communities of color, those in the marginalized communities. So what we have found is those cities that are fast track cities have been doing better than the global average because of the community engagement, because of addressing best practices to engage marginalized and key populations within their communities, and building resiliency when it comes to not just the HIV response, but public health response in general, and finding ways to include the social determinants of health into their public health responses. And that's one thing I would love to ensure that Nashville is included when it comes to that research, but also in enacting that level of response. And I'm confident that everyone here is dedicated to that as well. We all understand what we're up against, but anything I can do, or anything the network can do to help, please reach out to me. I want to make sure that Nashville is a premier city for fast track cities and ending HIV.
Dash, with these city-to-city meetings, what do those typically look like? Are they, like how long are they? I'm guessing they're virtual and not in person, but I'm just curious how others have looked.
So normally what's been happening is cities, they know of other cities that are doing work that they are interested in. Some of it is based on a practice. Others are based on developing a new way of doing something. And it's been virtual. They develop, one wants to do outreach to another, or says, we're interested in approaching, Toronto is interested in approaching San Francisco to develop a standardized stigma assessment for HIV stigma, to say this is a standard that we're all going to do throughout all of our city. So they identify what they need, what they want, what they're interested in. It's been about, I would say, they block off an hour, and they include stakeholders that are either part of the HIV response from the public health or from their Getting to Zero Fast Track Cities groupings to talk to their counterparts in that other city. I've not done any that are in person, normally because they're different parts of the world, not like you're going to fly to each other. But what I have seen them develop are twinning initiatives. So virtual, about an hour, and the results really come from what do they want to do. And for the Toronto, San Francisco example, they have developed a partnership to develop a standardized way of evaluating HIV stigma and having that be reflected from what they know Europe is doing as well. So twinning partnerships or different kind of working relationships or research partnerships sometimes come out of that. I highly encourage that as well. I'm interested to see what comes out of these meetings. It could be anything that you identify as a need.
So any other questions anybody has for Dash? And if nobody else has questions on fast track cities, Dash, I'll email you separately about September 30th. We can talk more about that. But I actually have to apologize. My husband has COVID, which means I'm on single parent duty today. And I'm hearing the baby waking up from her nap. So I'm gonna stay on the call, but I am gonna have to probably turn my camera off. So I apologize. And thank you so much, Dash, for that update. If it's okay, I might just quickly plug, tell you all a little bit more about the September 30th event before I have to kind of drop out here. So as I've already mentioned, this event is scheduled for September 30th, and it's really for anybody who wants to be either is currently involved in EHE or would like to be involved. And primary goal is really to kind of get people re-energized and get new people involved and get some of these new work groups formed and recruit people to the new work groups that we've been talking about on these meetings. And I do have a registration link ready to go. So if anybody has any thoughts about things that they think should be included in the agenda, please just shoot me an email and I'm happy to make sure that it gets included. And I will drop a link for people to register in the chat, and you can see more information about the event when you click on the registration link. And I realize that you all are very busy and a lot of you probably aren't able to make it on September 30th, but if you can share it with your networks, that would also be really helpful. And if you are able to make it, we'd love to see you there. Anybody have any questions about that event?
Will you send the invite player so I can get it on my schedule?
Yeah, I will. I'm working on setting up an email to send out, so I'll make sure it goes out to everyone on the council. All right. Well, then with that, I'm going to pass it over to Morgan, I think, is up next to talk a little bit about some of the new work groups.
Thank you, Claire. So in the last council meeting, during the discussion about new work groups, these were the work groups that you all suggested: HIV and aging, adolescent/young adult engagement, HIV testing, linkage to care, and looking at lessons learned from COVID-19 and how we can capitalize on that for the EHE movement. And then some other ideas for work groups that came up during the co-chair meeting that we had was a website work group just to manage the EHE website, and a data work group to make sure that all the data that we have on plan implementation is up to date and being communicated to the larger EHE community. And during the last council meeting, Dr. Brantley suggested reviewing current data to help inform which EHE work groups should be formed next. And so she's created a brief presentation about that data that she's going to share with us. Are you able to share it, Dr. Brantley, since you?
Hold on, let me,
Which,
because I cannot share content.
which one am I making a presenter? Because you're on here twice, so.
Oh, you're making the one that says she, her.
Okay.
All right, can you all see the slides?
Yes.
Okay. All right. So thank you, Morgan, for the introduction. I don't want to take up too much time, but I just wanted to offer some data and framing, perhaps for some of the conversations that we'll be having about just kind of future directions of this group and where we want to branch off into some new working groups. And just really starting with kind of a refresh on the plan goals. My aim with just kind of walking through some of the data points as it relates to some of the suggestions that were made, but also just kind of an opportunity to brief us all on kind of where we are, where we stand with the goals from the plan. So I'll be kind of walking through each of the 6 goals and highlighting a couple of data points for each. And then I'll share a couple of slides related specifically to testing, because I think that was one of the asks. But feel free to jump in as I go along. Sorry, my setup is a little different than I'm used to here. Okay. So thinking about the first goal, ensuring that 90% of residents living with HIV know their status. So in terms of tracking this, there's a methodology that CDC has developed. I included the reference at the bottom of this slide. It's fairly complex, but it relies on CD4 lab data to estimate incidence, prevalence, as well as the percent of individuals that are living with undiagnosed HIV in the US. And so we adapted that model for the state of Tennessee and then looked at different regions across the state, including Nashville, to estimate the percent of Nashville residents living with HIV that were aware or unaware of their status. And again, this is an estimate, so there's some error around, potential error around this, but the takeaway from this slide is really, while we're hovering around 87%, that's not far off from the goal of 90, right? Which is pretty good. That being said, there hasn't been a ton of progress made over the last, nearly 10 years. So, this is kind of signaling that we still need to do things a little bit differently, most likely to see an impact in terms of awareness of status. And then this slide really focuses on the goal of decreasing by 2/3 the number of residents with newly acquired HIV. So a couple of metrics here that are trying to get at this. So one, the figure on the left is using that same kind of modeling approach that I described on the previous slide to estimate incidence, which is really getting at the estimated number of new transmissions in a given year. And so here on this slide, just highlighting between 2015 and 2019, those estimates kind of wavered a little bit in 2019. The estimated number of new transmissions was 156. And so thinking about kind of the timeline of the plan starting in 2019 and then the goal of a 2/3 reduction, that would mean projecting out to achieve 52 individuals with newly acquired HIV in 2024. So it's a pretty stark drop. The other thing I wanted to point out, it's kind of a proxy measure for new acquisitions and it's something that we can we more routinely monitor, is the number of people who are newly diagnosed each year. And so this really gets at more so trends over time to help us track progress. But just important to keep in mind that when we're talking about new diagnoses, it's not an exact reflection of transmissions, right? Because it can include people who acquired HIV in a prior year or many years prior, but were just diagnosed in that given year. but then it also doesn't include people who are living with HIV and unaware of their status. So I'm getting a little bit at sort of data and measurement and like how we want to kind of track things moving forward. But really the goal for today is just to give you a better sense of progress and where we need to go and maybe where we want to focus some effort with this group. And then getting to linkage, so that third goal, linkage, linking 90% of those newly diagnosed with HIV to care within 1 month. So here on this slide, the first two blue bars are using data that we are using actual data, so from 2019 and 2020. And you can see the linkage rates are hovering around 74, 73%. And then again, kind of that projection towards that goal of 90% in 2024. So showing the progress that really needs to be made. I do want to say there's one caveat here, again, sort of with measurement. These data are based on the way that TDH analyzes linkage data within 30 days, which is slightly different than 1 month. I don't need to get into all the nuances, but when you kind of define it as 1 month, the numbers tend to go up a little bit. So if we wanted to go back and sort of change that definition, you may see a slight increase there. But that, again, the point is progress is kind of stalling out. And I'll show you in a couple of slides how this kind of ranges depending on the group of individuals in the communities that we're really wanting to reach. And then goal 4, engage 90% of people diagnosed with HIV and care. I know that there was not really an ask about linkage, but I did want to share, since we have the continuum of care data through 2020 for Nashville, just to let you know that we did see a little bit of a dip in 2020. It's probably in part due to the changes related to the COVID disruptions. And knowing that many individuals who may have been more actively engaged in care were not seeing providers as frequently in 2020, for example. Other thing I wanted to mention here is that the way we measure engagement based on sort of these standard CDC definitions, we're relying on having 2 labs reported at least 3 months apart in 1 year. And I recall when the plan was in development, there was a lot of discussion about, is that really a valuable measure of, identifying people who are in care? Because there are a lot of individuals who are in care at different points of the year, or maybe even just once a year, and that's okay because that's what's appropriate for that individual. So I did take a look at, in 2020, the number and percentage of people living with HIV in Nashville that received care at least once, and it was about 3/4 of individuals. So, something to think about as a potential other, metric that we may want to track, because that really shows that individuals are, the majority of people living with HIV in Nashville are actively in care at some point in the year. And then goal 5, ensure that 90% of those in care achieve viral suppression. Again, kind of this leveling off, 66% of individuals living with HIV were virally suppressed during 2019 and 2020. Also want to note here that the denominator here is actually among all people living with diagnosed HIV and not among those in care. So you may see, if we were to look at among only those who are in care, you may see different numbers there. So just things to think about in terms of how we want to monitor and evaluate our progress moving forward. But point being, 66% over the last couple of years with a goal of 90. We have a bit of ways to go there. And then just a note on disparities. I have a couple of slides highlighting, areas where we may want to focus. And there's, of course, already mentioned about youth, for example. So we're seeing in 2020, disproportionate rates of new HIV diagnoses continue to persist. I don't think this is shocking to anyone, but it doesn't mean that it's, still not an urgent issue. And so overall for Nashville, the rate of new diagnoses was about 20 per 100,000 And then when you start to break that down and look at cisgender males, about 35, young adults aged 25 to 34 was around the same rate. And then Black individuals had the highest rate of newly diagnosed HIV infection at 44.5 per 100,000. And then also want to make a comment that the proportion of people newly diagnosed with HIV that report male-to-male sex remains the most reported transmission risk factor, around 67 to 70% over the last 5 years. So there have been a ton of resources and efforts put towards engaging with the MSM community, but it's still, you know, there's still a lot of progress to be made. So probably lots to kind of talk about just on this slide. And then also want to mention linkage in terms of linkage to care and viral suppression. We're continuing to see disparities by among different priority populations, pointing out in 2020, MSM and Hispanic individuals were linked to care more than the national average. However, linkage to care and viral suppression were lowest among Black individuals and persons aged 25 to 34 years. So I'll pause there in case there's any questions about the data, and then I'll just spend a couple minutes talking about just the testing and kind of what we've seen over the last few years.
I have a brief question. So thank you so much. That was really interesting data, but I'm interested if you have any information regarding PrEP uptake, or if that's something later on, or if that's something that is tracked.
Yeah, so the kind of the next few slides are more about the programmatic outcomes. I don't have PrEP data to report on today. However, I will say so I'm from the Tennessee Department of Health, so I'm able to report on activities that we fund specifically, right? So we fund a few different organizations in Nashville to provide PrEP navigation services, and then we also support the Metro Health Department PrEP clinic. And so as part of that, we monitor and evaluate those data, but it's not the full picture of all PrEP services happening in Nashville, right? So I'm happy to kind of pull and share those data if that's of interest to the group. But I know others sometimes, you know, another source that is handy when it comes to PrEP prescriptions, you know, maybe the AIDS View dashboards that I think are pretty useful, and you can kind of drill into different cities and get a sense of the PrEP to need ratio as well as PrEP prescriptions, and they're pulling from much more like robust databases, not just limited to TBH. So a bit of background on PrEP.
Thank you. I'd be interesting if you have that information, you're able to do so. I don't want to put anything on your plate, any extra, but if that's available or something to look at, that'd be cool.
Yeah, I mean, so we have the PrEP navigation data, like, you know, it's like readily accessible. There's things, we monitor it routinely, so that would be really easily shared with the group.
Hey, Meredith, I have a clarification question.
Yeah.
Do our patients, are they counted in your N, or are you saying they're just the patients that you're funding through your own programs?
So if I were to present on PrEP data, Music City PrEP clients would not be included because we don't, you know, y'all don't like report to us because we don't fund you, you know, so it would really be a small, you know, like kind of a subgroup of people who are receiving PrEP services in Nashville.
But we provide monthly and quarterly reporting to y'all.
Depends on what you're reporting.
It's a form that you gave us. It's a form that TDH gave us. It specifically says new PrEP starts. It's asked for demographic information. It asks for STI information.
Yeah, it's probably related to the STI piece. I mean, I can lump it in. Yep. I think probably the way it's captured might be slightly different, but I mean, that's something that we could include. To the point, I can it's just not something our program monitors as regularly, I guess is what I'm trying to say, like internally. But yeah, we can,
The
I
reason
can
why I
try to
brought
get
it
my
up is, I
hands
mean,
on it.
I love your presentation, but until the last question from Dash, you know, when you have where you give the ends on the number of, you know, people living with HIV, who are aware of their status, et cetera, et cetera, et cetera, it's really great. But then I was a little startled to realize that maybe, you know, all the data we have is not in there, or maybe others. So it's only.
Oh, I'm sorry. Let me clarify. All of the data that I've shown so far is based on surveillance data. So it's everybody. It's based on statewide reporting. It's based on the labs that are reported to TDH on, you know, new diagnoses, viral load labs, which are mandatory. So, I'm sorry for the confusion. So when I'm talking about the PrEP data, that's like program. I haven't, you know, shared anything about that yet, but if I were to show PrEP data, it would be specific to TDH funded agencies. All of the data I've shown so far today are getting pulled from our surveillance data system.
Okay, thanks for the clarification.
Yes, thank you for asking that to help me clarify. Any other questions? All right, so I'm just going to touch on testing. Well, and here, this is kind of what I was starting to get at. But so, you know, some things that have been done, you know, a lot of work has been done around activities and strategies that are outlined in the EHE National Plan. Obviously, a ton of partners beyond sort of the scope of the TDH network, but I did want to share just from my perspective how we're, you know, hoping to support and continue to support the strategies in the plan. And some of the key activities that we fund: HIV testing, PrEP navigation, student services programs, condom distribution, and partner services, which is a health department specific activity. So our funded partners are included on this slide. So Neighborhood Health, StreetWorks, National Cares, the Metro Public Health Department, of course, and then United Way is one of our lead agents that helps us to manage some of the contractual relationships as well as community engagement in Nashville and across the state. So focusing in on testing. So wanted to highlight a couple of things. One, there are a lot of questions around the impact of COVID on HIV testing over the last few years. But then in general, just how are we doing in terms of testing in Nashville? Again, the caveat on the slide is that these are TDH funded HIV testing outcomes, so reflective of the agencies that we fund. The first group of bars reflect testing in the health department clinic. The middle group of bars reflect testing that's done in other clinical settings like emergency departments and jails. That's also inclusive of our partnership with Neighborhood Health. And then the last group of bars reflect non-clinical HIV testing, which is inclusive of our student services program at StreetWorks. And so Nashville Cares is a huge partner in all of this as well. And so that's the numbers that are kind of reflected here are really a representation of the great work of the agencies in Nashville doing this work. So you'll see in 2019, both the health department clinic and other clinical testing accounted for, you know, around almost 30,000 tests that year, and then non-clinical tests were around 1,300. And those numbers were really stable, I would say, over the last several years prior to 2020. And then, of course, we saw this huge drop at the health department clinic, as well as other clinical that dropped by, you know, almost 2/3, and then non-clinical by about a half. And those numbers kind of remained with a slight uptick in the clinical settings for 2021, just because of all the COVID disruptions. All that to say, you know, in 2019, the work is so important in terms of reaching those who are most vulnerable to HIV and those that would benefit from early testing and linkage to care. But a quarter of people that were tested just in the EDs, the jail, and the non-clinical testing events, a quarter of those, a quarter of all persons newly diagnosed were identified in those settings. In 2020, there was a bit of a drop there, but I will say the positivity rate among those who were tested by these partners remained pretty high. So any questions around this? Because there's kind of a lot to pull out here.
This is really great work. I think one of the things that we can do better as a council is try to combine our data as much as we can.
Yeah.
Because this is a great presentation, but unfortunately, it doesn't include our data, and I'm just kind of doing the quick numbers in my head. I think we're probably doing 20 to 30,000 HIV tests a year just by ourselves. So, and that makes a difference because it is part of goal 1, objective 2. And yeah, that's all.
Exactly. And that's something that I wanted to mention, and I'm glad that because you're obviously a huge testing provider, and just thinking about, who we fund, I'm naming 2 or 3 partners, which are amazing and doing great work, but there's such a vast network of medical providers and community service providers in Nashville. And so how do we, 1, reflect that work that's being done, but 2, how do we, maybe establish or strengthen those partnerships, right? At TDH, we would love to support or bolster, where gaps may exist. And that I kind of, on the next slide here, I just wanted to kind of make a plug that, we do have resources set aside to support testing, particularly by offering in-kind test kits for agencies that are eligible based on a set of criteria. But that being said, Rich, I totally agree. If there's a way that we can combine data and report on this more holistically, that's really how we should be tracking progress towards achieving these goals. This is one sliver of the broader network of work that's being done. So. Open to idea, and maybe that's the data work group, right? Maybe that's a mission for this potential data work group, to something to figure out. Any other thoughts on that?
I will say there are a couple best practices in integrating a lot of the data together that a lot of other cities have worked on. So I put up some links for the best practices. I think your discussions that you've been having as far as integrating data together is definitely something that I know other cities have worked on. But again, this is excellent conversation and definitely needed. But yeah, definitely.
Thank you for that. That's great. We'll have to look at those. The other thing I was going to mention, and kind of relates to, monitoring and reporting on the goals, of course, welcoming other partners that are doing this work, but just wanted to pull out a few things that we support and, dedicate resources towards. So, of course, that PrEP question that's already been asked. We also support condom distribution, syringe services programs, partner services, and some work around youth review education. So maybe for future discussion or for the data work group to take a closer look. So just wanted to mention that. I have one plug to make as kind of my announcement for later, because I might need to drop off. But before I do that, are there any other questions or comments? Okay, imagine we want to maybe come back around to this in terms of the work group planning. But before we do that, this is my little plug. So some of you may be aware the state is in the kind of information gathering stage of pulling together our next statewide strategic plan to address HIV. And it's under our End the Pandemic initiative, which is essentially attempting to jointly address HIV, STIs, viral hepatitis, and substance use disorder. And we've had regional-based meetings that have been co-led by community representatives and a nice mix of participants across the state. However, now we're really doing this push for kind of getting more robust quantitative data, as well as kind of supplementing with focus groups and in-depth interviews so that the representation of members and contributors to the plan is really reflective of the priority populations that we're trying to serve. So we have a couple of focus groups that will be pulling together in the next couple of weeks. And well, we have several, but two in particular where we, I think, really need help in terms of recruiting. And so wanted to share that here, and I can share more information later too, but focused efforts around engaging with the Latinx MSM community as well as youth. And so just a little bit of a plug here, and I can put some links in the chat later. So appreciate any ideas, or if you're willing to share, I can send out the flyers to the group. That's all.
Thank you, Dr. Brantley. Any more comments, questions about that presentation? If not, we'll move on to the next part of the agenda. So nominations. We have 5 people nominated currently to the council. I've sent you all the survey link to vote on those nominations. I'm going to put the survey link in the chat. And I'll ask that you go to the survey link and vote yes or no on the nominees. I don't know what's happening with Meredith's screen. So far 6
Sorry, is
council
that better?
members.
Did I fix it?
Yes. So far 6
Okay.
council members have voted, and we do need at least 8 for approval of new members. So if you could go and do that, that would be great. So
Can you put the link in the chat by any chance?
yeah, I'm not yet. I'm doing it now. Sorry. So I just dropped it in. And after we have all those votes, and those names will be passed on to the mayor for final approval. Any questions about the nominations?
So sorry if I missed this, Morgan, but I think there's one new nomination on there. Is that right? That some people who already voted may not have voted on?
Yes. There's a new nomination for Beverly Glaze Johnson. So if you have already voted, I will need you to go back and vote on Beverly's nomination.
Hey, Morgan, was that one wasn't on the one you originally sent out though, correct?
No, I mean, I updated the survey, so the same link it's all together on the.
So I'm getting something that says I can't vote on it because I already did.
Oh. Okay. If you haven't already voted, then go ahead and do that. And to those of you who have voted already, at this point, I'll send you a different link after this meeting. Sound
Morgan,
good?
just so you know, I have voted. This is Meredith. I have voted, and I was able to just pre-vote. So I'm not sure if that's a consistent issue. So.
What was your process?
I just clicked your link and it opened up. I don't know. That's about it.
The link from the chat?
Yeah.
Oh. Okay. I'm not sure. To everyone, I'll just resend. I'll make another survey just for Miss Beverly and send it to everyone who has voted. But I'm glad that it worked for you, Meredith. That's strange. Okay. So I'll pass it back to Dr. Bullock for questions, concerns.
All right. Thank you, Meredith. Just want to give anybody on the meeting an opportunity to raise any questions or concerns that you may have for this meeting or any meeting going forward, or just surrounding anything regarding the council at this time. None? Okay. Does anybody have any additional announcements to share with the group?
I have some announcements.
Go ahead.
The first one is September 24th is the grand opening for the 5 Points location for the PrEP clinic. That's also will be the site of the LGBTQ primary care practice that will be opening, the LGBTQ community center, and also Canvas will be opening up their East Nashville location there. So that's September 24th. The other item is we're working with Rachel Franklin at Metro Health on a monkeypox response. The HD went first today with their release about kind of relaxed criteria for post-exposure access to vaccines. The PrEP clinic will be announcing its plans probably tomorrow at the soonest. And we'll be coordinating vaccinations for our patients through the health department. And also we'll be doing testing for insured patients at the PrEP clinic. Uninsured patients will be going to the health department. That's the sum of it. And then lastly, we're preparing to send out an advisory to our community partners to let them know that we're going to have to modify our services that have been traditionally available because of the changes to 340B over the last couple years. What this mostly means is that in the past, we have provided all services completely free to all comers, regardless of their income or insurance. And we're going to need to limit the capacity or the availability of those services to some people. So that's a change that's coming soon.
Thank you. Any additional announcements by anybody else? All right, and we will continue to look for Claire's link to the EHE Summit, as well as the sign up for the invite as well. So be on the lookout for that. Thanks everybody for attending today. Our next meeting will be on October the 6th from 2 to 3:30, same time, same place. So thank you everybody for joining us today, and I hope everyone has a great rest of the afternoon and week.
Thanks, everyone.
Thanks all.
Thanks. Bye-bye.
Thank you, everyone.